Welcome. We are so grateful for your presence tonight. We are Union Baptist Church, and we are here with an online panel discussion. And I'm so grateful for your presence. There's so much we need to know about the COVID-19 vaccine. And tonight we know and we believe that you're going to get some good information. I'm also grateful for a very capable host and moderator who's going to help facilitate tonight, Dr. David Goatley, who is an associate provost, associate dean at Divinity School in Durham, North Carolina, and just a great friend and a great leader. And so I'll turn this over to Dr. Goatley so he can introduce the panel and introduce our night for tonight. Dr. Goatley.
Thank you, Reverend Rivers. It's good to be here. And the one thing he didn't say is that he's my pastor. So welcome. And we welcome you to tonight's webinar event, the COVID-19 vaccination, what you need to know. As you are aware, we are living in unprecedented times fraught with the deadly COVID-19 virus. While the pandemic has affected everyone, the virus has disproportionately impacted marginalized communities due to underlying conditions from healthcare disparities to economic and social conditions that negatively influence health. Tonight, we have invited a distinguished cadre of scholars and practitioners to discuss COVID-19 and the new vaccines. There has been a long-standing distrust in African-American communities when it comes to vaccinations. We hope to generate a robust discussion around what is fueling this distrust. As well, we hope to glean from experts as they have conversation about reliable, science-based information. And we hope that this information will help debunk some of the misinformation conveyed in the public domain. Our goal tonight is to make you aware of the facts so that you can make informed decisions about your health and the vaccine. Later tonight, we will open up the discussion for questions submitted by the audience. If you are on Zoom, you can pose a question in the Q&A function. For those of you on Facebook, you can place your questions in the comments section. I now am pleased to introduce our panelists. Cornell Wright is the Executive Director of the North Carolina Department of Health and Human Services, Office of Minority Health and Health Disparities. Mr. Wright's areas of expertise center around health equity and disparities, minority health, and community engagement. Dr. Michelle Laws is the Director of Consumer Support Services and Community Stakeholder Engagement for the North Carolina Department of Health and Human Services, Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. Dr. Laws leads a group on the COVID-19 response team that finds and identifies policies, services, and aid for historically marginalized populations experiencing the disparate effects of COVID-19. Dr. Ebuka Akinboyo is an infectious disease pediatrician and assistant professor of pediatrics in the Division of Pediatric Infectious Diseases at Duke University Hospital. Dr. Akinboyo's research focuses on enhancing methods for surveillance and prevention of infections among hospitalized children, particularly in resource-limited settings. Welcome to all of our distinguished panelists. I'd like to begin with a question and invite our panelists to respond as you are inspired. I want to first begin with a couple of questions about distrust. So one question is, why should people of color trust the vaccines, given the historical distrust of medicine from the Tuskegee experiment to the racial disparities prevalent in healthcare? Dr. Laws or Mr. Wright, would one of you respond to this question? And then after you do that, I'm going to ask the other to respond to a question with a little more specificity about the Tuskegee experiment.
So I'll go ahead and start, and if that's okay with my colleague, Mr. Wright. One of the things I often say is we are familiar with, either through stories we've heard, either through our own research and experiences also, about what I refer to as historical medical traumas. And Tuskegee certainly falls under that. And there's a whole, you know, archive in one book, Medical Apartheid, that sort of gives a whole litany of all of the different historical medical traumas that African Americans in particular have been subjected to, not just here in the United States, but also throughout England and Europe, especially dating back to slavery and to the antebellum period in the South. And so, like any trauma, that triggers our response to medical treatment, to medical research. So not only is there vaccine hesitancy, but we're seeing that decrease. But not only is there vaccine hesitancy, but we're less likely to participate in clinical trials, and we're less likely to trust medical practitioners, just on face value. And when I say historical, I mean historical as recent as yesterday, right? So people have experiences even in contemporary times, beyond Tuskegee, beyond Henrietta Lacks, beyond Dr. Sanger's radiation studies, in which babies and children, along with men and women, were exposed to high levels of radiation to test or see the effects of it on the body. Not only the Eugenics Project in North Carolina, where women, poor women, Black women, disabled women, people who were considered at that time mentally incompetent, or at the time we were using the term mentally retarded, were sterilized against their own consent and against their own knowledge in time. So I want to say that the historical medical traumas are doing what any traumatic experience would do, and that's trigger a negative response. And in this instance, it's the vaccine. But what I also want to say is, even with that knowledge, that this is not that. The COVID vaccine has been studied for decades, and also it's also some of the leading researchers, Dr. Kizzmekia Corbett, for example, a North Carolina native, has led some of the research on that. And so I just want to assure people that this particular vaccine is not that. One, it wasn't studied. The clinical trials didn't just include or didn't just focus on Blacks. And so that's one thing that's different from Tuskegee. And it didn't single out poor Black folk and so forth. This vaccine, the clinical trials were conducted included over 70,000 people. 10% of those were African Americans who participated in both the Moderna and the Pfizer clinical trials. And so this is not that. And I want to impress upon people that this is not the same as the medical traumas and traumatic experiences that have led us to be so suspicious and skeptical of medical research.
Thank you so much, Dr. Laws. You made mention of several traumatic experiences And one of them, and this is one that comes up often when people talk about the Tuskegee trials. And so, Mr. Wright, could you say a little bit about what the Tuskegee trials refer to? Sometimes people talk about, you remember Tuskegee, and then that's what they say. My hunch is people don't know what that means. Could you help us to know a little bit more about what that refers to when people express some reservation about vaccinations and the medical profession?
So definitely, thank you for having me. So Tuskegee, in this instance, is referring to a clinical study where African American men were observed getting syphilis, but were not treated for whatever reason. And so, what came out of this mishap, this mistreatment of people, is what we see in the protections that we call IRB, or Internal Review Board, where human subjects have rights, but also have protections from research. And so when researchers are going into communities or working with human subjects now, they have to go through this IRB process so that everything is on the up and up. There's checks and balances. So we do not repeat the mistakes that Dr. Laws so eloquently put in front of us to remember. And so not every system is perfect, but this system has been able to weed out any issues or potential issues before they become the traumatic experiences that we've seen in the past. And so when people say remember Tuskegee, it's referring back to the instance of how Black people were mistreated in a research study and not protected.
Thank you so much. That's very helpful. But from what both of you have said, it's very clear that the vaccines we're talking about, that's not the same thing at all with these experimental procedures on people without their consent. So, Dr. Akinboyo, could you describe for us tonight what a vaccine does in the human body? So people are talking about the vaccine. Can you help us to know just what does this vaccine do?
Thank you. Thank you for having me here tonight. We could spend hours talking about the different vaccines, but don't worry. I know this is not a service, so we'll keep it short and sweet. So I appreciate what Dr. Laws said. The technology around these particular vaccines have been in the works for years. But going as far back as the 40s, 50s, we saw a massive increase in the overall vaccines that were available, because we realized that things that are preventable were wiping out populations. So we had polio, smallpox, measles. They're things that we still see, unfortunately, we still see some of them, but there's some that people have never even heard about, or if they've heard about it, it's in the context of an odd picture they're trying to understand, specifically something like smallpox. So the idea behind the vaccine is quite simple. We know that our bodies can protect us, and a lot of people are encouraged to just go back to your roots, make sure you're sleeping properly, eating well, maybe take some vitamins, eat some fruits and vegetables, because it makes your immune system stronger. And we should be doing that anyway. But another way to help the immune system prepare is to almost give it a list of instructions, or expose it to a mild version of a problem, such as a virus or bacteria. Because when the immune system gets that little cheat sheet, it can get ready. It can prep itself. It can be ramped up. And so when it sees the real thing, you are ready to go, and your defenses are already prepared. So you're not spending time making those defenses. You're ready, and you wipe out the bacteria or virus. when we can create those things, and this has been years in the making, so decades in the making, for us to get to a point where we can go into a lab and generate these things, and they're different types. Sometimes it is a part of the virus. Sometimes it's the virus itself, but it's a little weaker. And sometimes it has nothing to do with the virus, it's just a protein. And so I can't go through all of the vaccines. I'm pediatrics, we give kids vaccines all the time. So we have a long history of using vaccines, and we know they're safe and they help us create that protective measure. And it just helps your already hopefully strong immune system fight off infections better. I know we have a lot more questions about the particular vaccines. I can jump into them, or I can see if you have targeted questions about the mRNA vaccines, which are just one type of multiple versions of protective vaccines that have existed and that are safe and effective at preventing infection.
Well, while we're talking to you, while you're talking with us, can you briefly, in kind of layperson's language, talk a little bit about these options of vaccines, as you just mentioned?
Yes, and always please pull me back if I get a little too technical. I switch each day from sort of a research talk, and then I go right back to a different type of talk. But so I'll give some specifics about the different types. So for example, I think we're all fairly used to the flu shot, the flu vaccine. It is a viral, so it prevents the influenza is a type of virus. And some people may get that it's a vaccine, but it's a spray into the nose. And some people may get the vaccine, but it's an actual shot, it's an injection. The spray into the nose is known as a live but weaker version of influenza. And we use it in kids all the time. They don't like getting injections. Some of them don't mind at all, but some mind. And we can give them a spray. It triggers the same response in our bodies. It just tells your body to get ready, create that protective defense. So if you see influenza in the future, you can get rid of it. Similarly, if you get the injection, which is usually inactivated virus, it's not live at all, it does the same thing. It just tells your body to trigger, get ready, and get prepared. And then there's a newer type. So so you could have a live vaccine. You can take it by mouth, take it as a spray in the mouth. Some people may remember babies get rotavirus vaccine. It's just something you put in their mouth, they swallow it, and that's how they get their protection. Or you can get an injection where it's an inactivated form of the virus. It cannot give you the infection, but it just tells your body to mount protection. And then the last one, because it's pertinent to our discussion that I'll mention, is one that we never discussed before last year, the mRNA vaccines. They already existed. So the technology for it's just a genetic, I will say mRNA, but all it means is it's a genetic form of vaccine. That technology has existed also for decades. The genetics I'm talking about has nothing to do with human genetics. The virus is very simple. It's a little circle, has those spike proteins. And the mRNA vaccine, they tried it for Ebola. They tried it for Zika. And let's just talk economics here. If the money wasn't there, and if it wasn't enough of a problem in the United States, there were not enough people working on it. And so money dried up, they focused on something else. But last year was different. There were a lot of people working on the exact same problem and a ton of money pouring into the exact same problem, and magic starts to happen. And that's what happened. The technology wasn't new, but all of a sudden the question existed. We knew the technology existed, and people worked hard to perfect it. It's just a slice of the spike protein, circle spikes in, those red parts that people see on the news all the time. And it just gives your body that instruction and tells it, get ready. If you ever see this, so it makes the spike protein, your body makes the protection. If you ever see this, get rid of it as soon as you see it. Because the vaccine has to travel with some things to keep it stable, the vaccine also has some salts, some lipids, just a slight fatty layer, sugars, to keep it stable as we move it from the freezer to where you're going to mix it up and then inject it. So that's sort of it's a fast way to try and summarize a lot of things. So if there are questions around that, I'm more than happy to clarify.
Wonderful. That is very helpful. And you have shifted very well today from your research talk to a talk to non-researchers. We're grateful for that. We've heard this evening from each of you, we've heard something about the details of what the vaccine does, helps our body to get ready, it gives us a cheat sheet. And we've talked a little bit about historical distrust and a particular event that was traumatizing. So for Dr. Laws or Mr. Wright, I'd like to ask you this one. Are you aware whether or not African-American scientists and doctors have been involved in this vaccine development process?
Absolutely. And I mentioned our, one of our stars, and that's Dr. Kiznikia Corbett. And there are others. We know that President Biden's COVID task force is led by an African-American woman as one of the leaders. And so, yes, there have been African-Americans, researchers and scientists working on this particular vaccine. And I want to just add to what our doctor said. I don't want to butcher your name, I'm so sorry, but about the resources that were poured into it. So not only did we have phenomenal people, African Americans included, working on this vaccine over a short period of time from our perspective, but certainly not from the perspective of the length of time that they in their own careers have been working, including Dr. Corbett, who have been working in excess of 6 years on this particular vaccine. And so I often say to people when they say, but it was just too quick, Dr. Laws. Reverend Laws, I hear you, but no. It just happened too fast. That whole warp speed thing, that threw me. And it was too fast. I'm gonna wait. Think about this. I tell people, if someone said to me, Dr. Laws, you can build a multi-million-dollar home, and the only stipulation is, or condition is, you have to use the money that's in your bank account right now. It would take me a decade or two to build a multi-million-dollar home in full transparency on what's in my bank account now. And I couldn't use any other funding source. It would take a decade or two, right? But if someone said, Dr. Laws, you can build a multi-million-dollar home and we're going to give you all the money you need and some, I could have a house probably built in a week or two, right? Depending on who the builders are and so forth. Because folk already know the blueprint, they already know what needs to be done, the land survey and all of that. So if I tell somebody, a builder, I can write you a multi-million-dollar check right now for you to build my home, I could get it up at the speed in which I wouldn't be able to if it was just my own. And so what the injection of federal dollars, and the sky was the limit. It was basically, we need a vaccine, we need it quickly, whatever it's going to cost, we're going to fund the research. So what do? They're able to bring in teams of researchers to focus on that one thing, that one vaccine. Not like in the past when you had one lead scientist and they had research assistants and they come in and cycle in probably through their training, their medical training and so forth. So I always tell people I'm sort of a lab rat, just only because I was forced to. My PhD came out of a med school program, VCU School of Medicine. So I saw people in there all day and all night in labs doing their research. Think about adding as much money as you can to contribute to a particular scientific discovery and what we can do in addition to the technologies that we have today. And so, yes, Black people worked on where our scientists, there's lead researchers at NIH, that CDC that are continuing to work in this space.
And let me piggyback off Dr. Laws and say, even with the amounts of funding that we're seeing put in to the vaccines, we're still seeing shortages across the country and across the world. So that is something, that in a normal time period, as she alluded to, that we wouldn't have seen happen, this way. And even with the extended grace and resources, a grace of resources, we still are seeing shortages. And so just think about how it would have been just in normal circumstances. It would have taken a longer time to get where we are now.
Thank you. It's helpful to know about the resources that have been going into the development. And now, Mr. Wright, you're talking, at least one way I'm hearing you talk about is the distribution and the delivery. So that on one hand, it sounds like we can have some degree of confidence to the amount of time and the skills, and also the inclusion of African Americans as well as others in the development. But when we talk about the distribution, Mr. Wright, let me ask you, do you have some sense of when the vaccine will be available to the general public? We read about kind of group 1, group 2, group 3, or group A, group B, group C. Do you have a sense, or one of our panelists have a sense of this distribution, that we're trying to unclog? When will the vaccination be generally available beyond special groups?
So I'm so glad that you brought that up. So one thing we need to clarify is making sure that we understand that the allocations that each state gets vaccines, whether it be the Pfizer or the Moderna, is predicated upon the federal government. So the federal government sends out the allocations of vaccine to the states, and then the states distribute it to the local areas based on plans that have been put in place since this past summer. We've been working on plans to get the vaccines out to the community. So once we had those plans in place and we looked at the areas of need and the areas that are most likely to fit into the different categories, then there was just a distribution plan. So when you go to our state website, yourspot.nc.gov, then you can see where you fit into the placement of which distribution group you are fitting in. Once you go there, then you know when it's time to start scheduling or attempting to schedule your appointments. We had an overwhelming response to our vaccine distribution, but we need to make sure it's an equitable process. So we're making sure as we get more vaccine that we're going through that supply, getting shots in arms, but also making sure that the practices of doing so in this distribution plan and process is done in an equitable fashion that everybody can receive quality health and vaccine as needed and required.
That's right. Can I share something related to that, if I may, just for a minute? Because this is I'm so glad you asked this. This is so important. This is another slide I was going to do, but I want to show you where we are in North Carolina. So this is I can't move that thing up to show it in video mode. If I don't know how to move that little black thing up at the top.
Yeah, we can see it. Mm-hmm.
You can see it. Okay, so let me just. I want to show you. So this is the chain. This is the distribution chain that Mr. Wright was speaking about. So the federal government decides how much we get. We then follow this chain, in DHHS determines which providers, and right now the providers are, the distributors are the local health departments, medical facilities, long-term care facilities, and 2 pharmacies, Walgreens and CVS. And so they get their distribution that's shipped directly to them from the manufacturer, and then they distribute according to our distribution plan. But what I want to say is, currently, this is how or who has received the distribution of the vaccine. And I'm bringing this into the conversation because it's important when we talk about equity. 81% of, so the light blue, the Carolina blue, Go Tar Heels bar are the first, represents the first dose, and the dark blue, the Blue Devils colored bar, represents the second dose. If you look at this graph chart, you will see that 81% of white folk in North Carolina, and some from outside, 81% have already received their first and their second dose. African Americans, 12% first dose, 10% second dose. American Indians, 1% for each. Hispanic and Latinx, 2% and 4%. I bring this up in this conversation, and this just says how many, I bring this up in this conversation because I want to also, and this is the distribution plan or the eligibility criterion. Right now, we're still with the older adults, 65 and older, healthcare workers and so forth. But what I really wanted to say is that not only has the distribution been inequitable, but the deaths have also been distributed inequitably. African Americans make up 25% of North Carolina's population, and yet though we make up 25%, I mean, we make up 21 to 22% of the population and 25% of the deaths. And since I've been working as one of the leads on our HMP strategy, it has been in this range. It's slightly lower at times, but certainly not at the level that we want to see it. When we look at the cases, the 20% is low compared to the history of this pandemic in our state. And when we look at the total cases for Hispanic and Latinx, they make up 22% of the cases. So there's disparity there because they make up less than 10% of the population. But if you go back to the deaths case, death stat, you will see that they make up, and it's not only because 664 deaths or 664 deaths, they make up 8% of the deaths. And so we are not only as African Americans disproportionately throughout the history of this pandemic in North Carolina, shouldering a disproportionate burden of the cases, but also of the deaths. And this is just where we are today, 9,409 deaths in North Carolina. But this figure I wanna impress upon us as it relates to the vaccine, and then I will be quiet on this. The average daily 7-day death, number of deaths in the United States is 3,156. When you think about, I fly Delta because my mom used to work for Delta. So I fly Delta, that's my preferred carrier. One of its most commonly used passenger planes is a Boeing 737. The seat capacity is 160. If you divide 160 into that 3,156 7-day average, that's 19. So when we think about deaths and we look at this using this symbolically, that's 19 planes. And before, when I gave this about 3 weeks ago, I think it was, Mr. Wright, it was 22 planes. So the daily, 7-day average has gone down. But when you think about that in terms of airplanes, that's equivalent to 19 airplanes falling out of the sky every single day. And we also know that African Americans are 2.8 times, and as well as Hispanics, 2.8 times more likely to die from COVID. So that means on these 19 planes that are crashing, African Americans are 2.8 times more likely to be on these planes and dying. And so when we think about this vaccine, and when we think about the hesitancy, and when we think about what's at stake, it literally is a matter of life and death. It's not the panacea, so I don't want to oversell it, but it's certainly a way for us to get ahead of and to flatten the disparities curve that we are seeing across indicators in this pandemic. And that, coupled with the vaccine, coupled with the prevention measures, wearing a face cover, covering your nose, a mask, covering your nose and your mouth, washing your hands and down hard surfaces, keeping the social distance, not letting folk in and out of your house, as my grandma would say, is important.
Thank you so much. I think all of us are learning a lot. Dr. Akinboyo, you mentioned earlier about different kinds of vaccines. I'm sure some of our listeners would be interested in knowing, from your perspective as a physician, is one vaccine brand more effective than another?
It's a good question. It's amazing that we're at a point where we have a choice. And I think I just want to sit with that for a moment, because a couple of months ago, we were not even sure we would have a working vaccine. And now we have two choices, and we actually will have more over the next few weeks. Focusing mainly on the two that are available. So we call them by the company names, so Moderna, Pfizer. Practically speaking, they're fairly similar. Both of them contain that instruction manual I mentioned, the mRNA. Moderna has a little bit more of the instruction because you store it at a slightly warmer temperature. And because just think of the instruction as friable paper, because it can break apart fairly easily, they added a little bit more. So just in case a little bit of it breaks apart, you still have enough so you can read the entire thing, or your body can read the entire thing. So that's a subtle difference. It doesn't really change much in terms of how it makes your body work to protect you. So both of them, the efficacy, if you look at, you're following all the trends, one is 94, one is 95, doesn't matter. Fairly similar. Content, fairly similar. And they've been very transparent. Usually pharmaceutical companies, for monetary reasons, choose if they want to release the entire ingredient because someone else can make it. And to ensure that people are clear about what went into the vaccines, they've released the entire list of things they put in, and it's publicly available. It's on the FDA's website, and we can share it as a resource. Side effect profile, fairly similar. I have been vaccinated. I'm a healthcare worker. I work in the hospital, see patients. I was in the category, whichever one you want to call it, phase 1, 1A, 1B. And so I received my vaccine. I received Pfizer. I've had colleagues receive Moderna. When we compared our side effects, after my first shot, I was fine. Had a little bit of arm soreness, but it went away in a day. Second shot, I think my buddy wanted me to know that they were preparing for something. So I did have a few side effects. I had a slight headache. I had a fever. I haven't had a fever in decades. I can't remember the last time I had a fever, even with mild colds. So I had a slight fever for about a day or so. And then I was fine soon afterwards. I personally took Tylenol. Some people choose to power through. I think my body's smart enough to figure out it can still make protective antibodies. And so I was feeling a bit uncomfortable and I took Tylenol, but you don't have to take it. You don't have to take it beforehand. I had a colleague that got the Moderna vaccine. First shot, also similarly fine. Second shot, nothing really happened. Someone had slight fevers. Head to head, if you have a choice, please take the one available to you. They work just the same and should help you create those protective cells, protective antibodies, regardless of the one you take. While I have the floor, I'll just say one thing. There are other vaccines coming out that have slightly different technology. I've focused a lot on mRNA. Some of the newer ones have adenovirus. They have other viruses you hear that serve as vectors, almost help with mission control, so to speak. So when they get in, they know where to go. And so if you have questions, please ask those questions and seek answers, because there may be slightly different technology coming out And you hear different numbers. One will be 60%, one will be 75%. The Russian one is this, the Chinese one is this, or whatever. But the goal is, if it works, if it goes through the authorization process, if it's being distributed, it is a safe and effective vaccine as far as we know. And so if it's available to you, you should likely take that one, knowing that we continue to have vaccine shortages. So the goal is just whichever one you have in front of you, please take it.
Thank you so much. For our listeners, we do want to remind you that in this time of conversation about the COVID-19 vaccination, what you need to know, we're trying to help enlarge the conversation and make more information available. We do want to encourage you and remind you to confer with your physician, and you'll have more knowledge and to be able to ask more informed questions. If you do have questions, if you're on Zoom, you can type your question into the Q&A box. If you're on Facebook, you can type your question in the comment. We do want to say that we will pose questions of a general nature to our panelists, and we won't be able to pose a question that will be specific to someone. We want to encourage you to have specific conversations with your physician. So we have a couple of questions that we would like to raise to whichever of our panelists are inspired to do so. So we have one question by one of our colleagues who are on tonight that says that there's a lot of information, there are a lot of questions about additional strains of COVID-19 and the effectiveness of the current vaccine against them. How effective are the current vaccines against those strains? And can we expect new vaccines to keep up with new strains similar to the flu vaccine? So there's a lot in there. So whichever parts of it that you will be inspired. But I think that the main question is, talk to us about these new strains and whether the vaccinations that have been developed are useful. And, are we going to have to keep on thinking about new strains? Any of our panelists? Thanks, Doc.
Yeah, I can start it off. I think we're all hoping this will be over soon. And then each month we wonder when it will be over. Before I address the question about vaccines, and I will, I think I described the virus, tiny, small particle. It only mutates if it's replicated. So what I mean by that is the virus needs humans to continue to spread. The more we spread it, the more we'll see new strains develop. If it's not spreading, there would not be a pressure, there would not be a need for new strains for it to evade our system. The virus is figuring out ways to evade our system. Think of it as a game kind of thing. So we can do a lot to prevent strains, even outside of the vaccines. All the things we know work, washing your hands, wearing a mask, staying distance, would help with reducing spread and should reduce new strains. So now to address that question, and this takes a lot of nuances and understanding how the vaccines work. The short answer is, for the most part, the way they created that list of instructions is to ensure, so the mRNA portion is to ensure that it can cover more than one type of strain. But the recent strains, and they've called it according to locations where they saw it spread. Unfortunately, we may start to associate those locations negatively. So I'm trying to not just use the terms, but yes, it's based on the city or country where they found it. So it's right now, South Africa, UK, as one from Brazil. There may be one from California or Florida before we know it. So it's less about where it's found and more about the fact that they seem to be stickier, so they changed those spikes. So remember the circle and the red spikes around? The virus has changed it just a bit. That seems to make it slightly more contagious. And that's why we saw spikes. If you take your mask off and you have a stickier virus, you may be more likely to spread. Because the vaccines were made to account for some subtle changes, they may still work. And some early data suggests they work really well against the one that spread rapidly in the UK. Same data, very early data, suggests that they may work just a little bit less against the ones from South Africa. But what does that mean practically for all of us? The way the vaccines help our bodies create that protective element, just tossing some numbers out here, just walk with me for a second. Let's say we make 100 protective cells and they work against the COVID-19 we knew about last year. All the 100 work against the UK variant. What we're seeing is against the South African variant, we're only able to make, say, for example, 75 of those cells, not the entire 100. Still some protection, but we don't get the entire 100. And so for some people, we may see more spread with that particular variant, and we may see that continue to happen across the board. So what's the take home? The take home here is certainly make sure when you do get vaccinated, you get both doses. Because first dose, you may make 50 cells, second dose, you make the entire 100. So ensure you complete the series so you're well and truly protected against what we know. Second part is we all need to do what we can right now to ensure that the viruses are not using us to create mutant strains. That's the simple truth. The more we do right now, the better it will be for all of us. And then the last part is, yes, there is a potential that now that the technology is well and truly working, there's a potential that the companies will be trying to stay ahead of all the strains and may create booster shots. I don't expect us to have 1, 2, and 3 in quick succession, sort of in the next, you start to have 3 shots in 3 weeks. It may be that in a year, in 2 years, you may need a booster. It depends on how this changes.
Thank you so much. We're getting a real good lesson tonight. We're getting information. So as we go talk to our doctors, they're going to be impressed and they're going to want to know, how do you all know that? And people are going to say, well, we've been to Union Baptist Church. Mr. Wright, some of our colleagues are wondering that when I get my vaccination and I get all the doses, do I get to just do what I want to do? Do I go where I want, do what I want? All of these protections that we've been doing about washing hands and social distancing and wearing masks and traveling, to see folks who are not in my household. Can I go back to life pre-COVID once I get vaccinated?
So the simple answer right now is no, not yet. Once you get your second dose, the body still has to communicate that across the body into the antibodies. So it's going to take even some time for you to reach that cell count that the doctor was mentioning to have that 95% protection that we've seen in the trials for the vaccines. So at this point, until we can reach what is called herd immunity, or where we've gotten to a point where enough people have been vaccinated and the bodies of those people that were vaccinated have responded to be able to protect each other and ourselves, we're going to still have to wash our hands. We're still going to have to wait 6 feet, and we're still going to have to wear a mask. We're still going to have to, kind of stay in our homes until we can get enough people vaccinated. And clearly, as we stated earlier, we just don't have enough vaccine to get to that point yet. So my recommendation is to not go back as life as usual before COVID, because you still have a potential, even after getting your second shot, you still have a potential of catching COVID-19 if we're not protecting ourselves.
Thank you so much. We are approaching soon our time where we're going to say good night to everyone. But before we do that, for each of our panelists, Mr. Cornell Wright, Dr. Michelle Laws, Dr. Ibukan Akinboyo, we are so grateful for the gift of your time and your wisdom to talk with us. We are grateful for the work that you are doing in this space. We want to ask you now to take 90 seconds to 2 minutes to say what you want to say. You only got 2 minutes left to tell us whatever you want to tell us. So talk to us and tell us what you want to say. We'll start with Cornell Wright. What would you like to say to our listeners tonight?
Well, thank you for having me be a part of this panel. It is very important, as we've stated throughout this this panel discussion, that we continue to adhere to the guidance that's set forth by the governor of this state and our Secretary for Health and Human Services, Dr. Mandy Cohen. We are trying to make sure that we are saving lives. And one way to do that is to make sure we adhere to those guidances of wearing our masks, waiting 6 feet, washing our hands and washing our surfaces, staying out of homes and keeping people away from our homes as well that are not normally in our homes. That is one way to prevent further crisis from happening. And if we're trying to protect our elderly or our children and our families, our friends, our loved ones, and our neighbors, then we have to do what is right, not only for ourselves, but for others. And that is adhering to those guidances and staying safe. So hopefully we've given you some information that can allow you to make an informed decision one way or the other. And if you need any information from us, we are always available to have that conversation or send you to the right resources. Thank you.
Thank you so much, Mr. Cornell Wright. Dr. Laws, what would you like to say to us before we leave you tonight?
First, I want to say thank you, Pastor Rivers, for the vision to have this important conversation. This is what we need to have more of, especially among trusted sources and leaders. And we know the role that our faith communities play, especially in the lives of African Americans. Since it is Black History Month, Carter G. Woodson once stated that the mere imparting of information is not education. So it's important that people are getting factual information to make educated decisions about their health, and not just with this pandemic or this virus, but about their health in general. And so I encourage everyone not to listen to everything that they're seeing in social media, but to use opportunities like this to hear from practicing physicians and medical researchers, physicians like Dr. Ayu and others who are out on the front lines helping to spread factual information to help us make good decisions. I also want to say, people who I've heard folks say, you know, what does this have to do with religion? I'm just going to pray about it. God's going to keep me covered. You know, I'm not taking the vaccine because God's got his hands on me. God may truly, and I believe, have his hands on you. But I want to quote Albert Einstein, who said, "Science without religion is lame, and religion without science is blind." He said, God is a mystery, but a comprehensible mystery. I have nothing but awe when I observe the laws of nature and his work. So the two go hand in hand. God has blessed us with some wonderful researchers and scientists and the like. Trust the science. Trust the science. Beloved, I pray, St. John the Apostle said, that in every way that you may succeed and prosper and be in good health, just as your soul prospers. That is my wish for everyone. I need you to get vaccinated. I need you to understand that we are at a critical stage here in this state and across the country. African Americans cannot afford to not be in line to get their vaccine. This is not Tuskegee and the others that I mentioned. Supply is low. Demand is outpacing supply. I tell you to be patient and to practice the 3 W's that Mr. Wright talked about. And thank you. It's been an honor to be here tonight.
Thank you so much. Dr. Akinboyo, what would you like to say to us before you leave us tonight?
So I want to thank you. I want to thank the audience for the attention, for even choosing to be here to listen to this. I thank you, Pastor Rivers, for having us, for facilitating this. And Dr. Goatley, you have done an awesome job as well as my colleagues and the co-panelists on here. So I think I just wanted to commend everyone having the conversation and continuing to have the conversation. We certainly cannot address every single aspect. And there's so many historic, and I love what Dr. Law said. It's not that historic, it's yesterday. Women are still afraid to have babies, especially if you're having a Black baby in America. And that's a problem. And that's a problem we all need to fix. That being said, there are people that are called to work in medicine, that are called to research, that practice their faith in this every single day. And people are not here touting snake oil. There is a reason why you saw fear in healthcare workers. We know what we saw. This was different. And there's a reason why we can't afford to have Black people continue to die. The vaccine can help. It's not going to solve all our problems. Yes, some people may still get infected even after being vaccinated, but they are less likely to die, and that's important. We don't think it's going to affect pregnancy. We don't think it's going to affect the legacy you're trying to build, your reproductive health. But we know it's not all the answers, but we need to be in line since the line is available, and we need to fix all the access issues so those that do want to get in line can get in line. But let's keep the conversation going. The lines are open. You can find physicians of color. You can find Black physicians everywhere. You can find Hispanic physicians, you can find anyone you trust, but make sure it's a trusted resource. And then the last thing I'll just end with is the virus itself doesn't know if you're Black, white, Puerto Rican, Chinese kind of thing. The virus doesn't know. It's everything else that worsens the outcomes when you get infected. The virus doesn't know your race. It's not the virus itself that's racist. There are a bunch of other things that add to this, that lead to those complications. So please just keep that in mind as you see data, as you hear about cases, as you hear about solutions, and let's keep the conversation going.
I'm David Emmanuel Goatley. You've been a part of a conversation, the COVID-19 vaccine, what you need to know, hosted by Pastor Prince Rainey Rivers and the Union Baptist Church. We say thanks to Dr. Ebukan Akinboyo, Dr. Michelle Laws, Mr. Cornell Wright. Pastor Rivers, thank you for hosting us and giving us the opportunity. We'll yield to you for the final words for this evening.
Well, thank you, Dr. Goatley, and thank you to all of each of the panelists who came on tonight. I've been on interviews and on panels, and I learned so much tonight about the vaccine that I'm so grateful for the knowledge that you shared. I know our participants gained some deeper understanding, and that's what we're really trying to do. Thank you for keeping us safe. Thank you for the work that you do every day. I like what Dr. Akinboyo said about people being called to do this work. We sometimes think that calling is limited only to people in professional ministry. But I believe that each of you is called to do the work that you are doing. And I commend you for doing it, especially the risk that some of you had to take to continue to do your work. And I hope that the members of Union Baptist and all of those who will hear this, even as it continues to play on demand, will take heed to the advice that was given tonight and the wisdom that was shared tonight, and that you will make sure that you and the people you love are vaccinated so that you can spend many more years together and celebrate life. Thank you all for coming. I hope that you will take the poll that is on the screen for those of you who are participants. We just want to know who's getting the vaccine and will you take the vaccine, so we'll know how many more of these panels we need to do to keep people safe and healthy. Again, thank you, Dr. Goatley, for your excellent leadership tonight, and to each of our panelists. And we say good evening to all of you. May God bless you.